So I am Margarett Shnorhavorian, and thank you, Paul, for that overview, because I think the boys and the girls share experiences, and I'm going to take a moment to just say thank you to all of you. As someone who cares for kids and families with exstrophy, this is truly an honor for us, and I feel that this title really doesn't limit me. Is what I want to come back to. Because this concept of a defect, I don't see bladder exstrophy as a defect, it's a difference. This concept of normal, I don't see it as a thing. There's typical, there's optimal. And I do believe, because I've seen the kids grow up, because I started in Seattle in 2005, and what brought me to Seattle was bladder exstrophy. And working with Dr. Mitchell, and working with Dr. Grady, and working now with our big team of Dr. Margarett and all the nurses, and it's expanded, and you see that it does take a village, and the village is really an honor to be a part of. And not only at that early time of closure, which we all focus on, and back in 2005, it was thought of as an emergency, and we were scrambling to get to the OR immediately. And now we recognize really the best approach is to get the team together and give you the best team possible. And then recognizing though that you need that team over the long haul, because your kids grow and develop and are on this journey. And I hope that you do have a team that's with you throughout that journey. I'm going to share a couple concepts that I want to come back to the previous talk. I'm going to see if this clicker works today. Okay. So, I think it works. I'm going to get back to a theoretical concept, which you may have heard, but when you think about bladder exstrophy, it's this open book difference. And the idea is that we're going to close the bladder neck and urethra as a single unit, and restore bladder cycling and restore bladder function, and let the bladder heal and grow. And we don't know which bladders heal and grow and which don't. And I will say, I do believe in patience, but I'm not that patient. So I think, to Paul's point about patience, I think there is a role for patience. And I think there are a group of kids that really do need to support you earlier. And we just don't know which ones those are yet. They've looked at tissues and all sorts of parameters that could potentially help us predict. At the end of the day, this is this kid and this bladder and this body, and I think we need to honor that and the differences. So optimizing function is important, and I do want to speak to a couple questions that I heard. I'm going to go a little off track with all the slides, but I'll get to that and I'll shorten it so that we can get back, because we have some amazing speakers. So that concept of allowing the bladder to heal, allowing the bladder to cycling. The other piece about the genitalia. So a big focus of my work is around fertility preservation, testicular development, and if you were to really think about things, it's really two sides of the same coin in terms of how the testes and ovaries develop, in terms of how the clitoris and the glans penis develops. We really are very similar structures. And to the concept about the male phallus, I just want to say that when we see these kids over time, go for optimal. You go for functional, and you go for a healthy life over the long term. And so I don't know if surgery fixes that. And so I think it comes down to supporting all of you as the parents, as the family, as the kid, because I think building that confidence, these kids are amazing, and you know it. I mean, they are cheerleaders, they are valedictorians, they are all-star baseball players and hockey players, and they're incredible kids. And I also have told many of you in this room, they're also some of the most beautiful kids because they have perfect symmetry, right? So look around the room, this is a group of really good-looking folks. So not that that's important, but it is. So I'm biased, okay? So I'm going to also share the second piece. So Dr. Mitchell used to comment on this really big philosophy around bladder healing and bladder cycling and growing. And we just need to know how kids grow, and every kid grows differently, and who needs that surgery for bladder neck reconstruction and who doesn't, or who needs the augment and who doesn't. And I think we're still learning over time. And we can look at numbers, but we have to bring it back to you. The second thing I want to quote is Dr. Brady. So in 2005, when I came here, we were looking at the boys, we were looking at the girls, and the clitoris is bifid, right? So it's the penis. And this concept of normal anatomy was something we struggled with because really the goal is function and optimizing function. And so having the bifid clitoris, but bringing the clitoris close together, optimizes function. And it promotes cosmesis as well. And this has been a radical change over the last 20 years in terms of how we think of the genitalia. And so this is optimal genitalia. And Dr. Grady used to say, are there any kids in the room? Just curious. Having a bifid clitoris, one of his young women, patients, told him she thought having a bifid clitoris was the door prize to being born with exstrophy as a girl. I get chills. I feel him close right now because I could hear him saying that. And so there have been big debates in the surgical community about optimizing function, sometimes over cosmesis, for giving that girl that door prize. Being born with exstrophy, I think, is pretty amazing. And so those are two big concepts I think I want us to keep in mind. And then this third concept, as you've heard, is really over the lifetime. We need to support kids. But you know what I've learned, and I take care of a lot of kids born with very severe differences in sex development. And what I've learned is that we need to support the moms, the dads, the aunts, the uncles, the grandparents, in recognizing what an amazing, healthy child they have. I'm going to say that again. So you're born with bladder exstrophy, you're holding this baby with bladder exstrophy, congratulations. You have a healthy baby. We're going to help you keep that baby healthy over time. And I think that's an important concept. We need to support you in supporting that child and remembering how amazing they are, because I think there is this potential pitfall in focusing on normal or what is perceived. And that's true of all kids, many of us who are parents, the Instagram generation. So blah, 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 blah. I hope I got that out. I just wanted to make sure I made those few points, because sometimes we get lost in the slides. But I want to bring back a couple concepts that I'm going to share, and then I'm trying to wrap up so Amber has time. So we heard about urinary continence, we heard about optimal renal function, functional genitalia, satisfactory cosmesis, and I think I spoke to you about this concept of urinary continence around bladder cycling, about optimal renal function. Yes, the goal is protecting the kidneys no matter what, but that's part of long-term care, right? Functional genitalia, I think, is really a focus, and what we're learning more and more, and satisfactory looks. And the clicker stopped. Next slide. So you heard a little bit about the natural history. So this is a really nice picture in terms of how the clitoris and phallus, the glands, can be separate, right? And so they're just brought together in the midline with a variety of techniques, which we'll discuss. Next slide. Next slide. Providing functional genitalia, I think I talked a little bit about that. It really is about optimal, and these are functional over time. Next slide. So just long-term follow-up, I'm echoing, a lot of this is similar for the boys and girls. Next slide. Next slide. What's really fun is seeing also the emergence of gynecologists being a part of this village that I talked about, which is so fun. Yes, heart to you. And realizing all the roles that we have on the team. And so as a pediatric urologist, I'm very comfortable wearing a microscope on my head and operating on a really tiny area. But that tiny area grows over time. And so having the big girl team is really important early on, but also later, and working together. But recognizing that prolapse can occur, so those folks are going to talk about that. Next slide. And again, you heard a little bit about the normal anatomy, and I wanted to bring this home with what I started with, which is we're going to go from a bladder exstrophy to more typical anatomy, and bringing that clitoris to the midline, putting the urethra deep in the pelvis, and treating the urethral bladder neck as a single unit, recognizing the diastasis. Next slide. So this is a cross-section of how all of that is up top, and we're kind of bringing it down deep and then bringing the clitoris together. I actually have video of surgery that I borrowed from Dr. Krieger's group, but I wasn't sure if this group wanted to look at I love surgical videos, so right in your little, I have had to have parents sit down when I show them pictures of them, but if you want to watch videos, I'm happy to share videos anyway. So this is, I borrowed this slide from Dr. Margarett, the Georgia O'Keeffe G-rated version. These women do well. They do well, but in the areas where they're not satisfied with appearance, I think we need to recognize a lot of people are not satisfied with their appearance. Hello? We actually in our DSD clinic talk to girls about how there are hundreds of different labia and, kind of normalizing the range of normal, I think is really important. So normalizing that everyone's different, and that's okay. So I'm not a psychologist or anything, but I think there's only so much a surgeon can do. But a lot of it, and we can take the anatomy that the child is given and make it the best possible it can be. And then from there, I think there are areas where we can support surgically, medically, and then I love this theme of bladder exstrophy doesn't limit, and the psychosocial component I think is key. And sensation, I think this point speaks to older techniques that we're focusing on normalizing anatomy. Making a normal-looking clitoris may have been the trade-off for function and sensation. So I do think we're going to see this whole new generation of young women who've had that door prize kind of maintained, bringing the clitoris together and not manipulating them in what I call the Grady ones plastic, because it was Dr. Grady who came up with that idea almost 20 years ago. And I've never done anything else in my career. But I think we'll see that when you optimize function, cosmesis is still there. We'll see an improvement there. So thank you for that slide. And this is just patient-reported outcomes. I'm going to just acknowledge how important it is to work with all of you. And Pam, it's so amazing reading this community of families and kids with bladder exstrophy, because I think working together is how we're going to make it better for the next generation. And so go to the next slide. So we know there's limited data, you've heard about the limitations, but we want to look at a group of women who tell us how they're experiencing their sexual function and their reproductive function and urinary outcomes. And so this was with you, bladder exstrophy, and I think Dr. Anna is going to talk about an area I'm very passionate about, which is working with you on how to improve the care of the next generation of kids. So this was a platform. Next slide. Thank you for responding, those of you who might have been part of it. Primarily US, but others chimed in. And many had had a lot of surgeries. Did you see that median number of 10 surgeries? Whoa. So I think the goal is to minimize surgery and optimize when we do perform surgery. And so this was using to the point about how do we define continence. So this is a group of people coming together saying this is how we're going to agree to defining continence, and I think it was a relatively appropriate way to go. Obviously, everyone's going to define differently, and in the paper that Dr. Margarett pointed out that I led, we define continence as dry and pee. You can define it as dry and catheterizing. In any case, so here with the standard questionnaire, 40% never leaked, and then about 7% leaked all the time. Next slide. We don't have their surgical data, right? Because this is a self-support report, but I think it brings to light what I'm going to talk about, which is hearing what's important from the individual. So how much do you usually leak? Really, the majority do well. I mean, small amount. There's no controls, and I think if you look at women of a certain age, I don't know how many of them would say the same, and it is a really limitation because we're going to compare to healthy controls. And I don't like the word control either, but anyway. So does it interfere with your life? Probably not. Next slide. And when does it leak? It leaks, kind of before you get there in time or when you cough and sneeze. Exercising, so stress incontinence, which is common in women and probably more common in women with exstrophy. And looking at how their bladder was managed, a big chunk of these people were having to catheterize. And so one of the pieces was, are the women who are drying and are leaking the ones who are catheterizing, right? Next slide. In terms of reproductive outcomes, infertility was an issue, as well as dealing with the challenge around that. That's a really loaded topic around what led to infertility, so we only have that they struggled with it in terms of the definition of being tried for a year to become pregnant. But a third did become pregnant of those who desired to. And the majority required a term delivery by C-section. I don't want to get too much into the gynecology literature, but we also looked at our series here at Seattle Children's, working with an MFM group, maternal fetal medicine, and how to approach the female with exstrophy to have a successful pregnancy outcome. This miscarriage rate, I think, deserves more understanding around that, and maybe separate from the exstrophy itself, because we know that exstrophy is not a gene difference, so that's something in terms of how the area developed was different. Next slide. Next slide. And this is an important area of recognizing how to support a healthy pregnancy. A woman with exstrophy who's pregnant does need a special team. Next slide. And uterine prolapse is significant, as well as vaginal stenosis. Vaginal stenosis is when the vagina doesn't grow with the child or scars down, and that can be approached with a variety of techniques. I don't know if you want me to talk about that, but we work a lot with non-surgical approaches. Again, dissatisfied with the appearance of the external genitalia, I think we could do a lot better job of explaining optimal anatomy, explaining functional genitalia, and then also if there is a role for refining the labia or refining the genitalia. And I will say this is an important, someone asked about the age. When it's not a functional issue, I think we need to honor the fact that most teens are not really happy with their appearance. So when we think about a healthy teen, that's kind of very normal. I just use the word normal, but it's very typical. And so I think we tend to wait till they're ready. And really, age 18 is the age of consent, but every individual kind of develops a little differently. But I think their sense of themselves does change through adolescence, and I think we need to support them with that and then help them make the right decision for themselves. And this is the Female Sexual Function Index. Where are the issues for improvement? And I think these are areas that need to be discussed with the woman and identify, is it a lubrication, is it pain? And if it's pain, that needs to be addressed for sure. Desire arousal can be more around hormone management. Next slide. Or perception. And so a little bit more of a dissatisfaction than a woman without exstrophy, but really not that bad. Next slide. But this is really key. I think what are the topics that are important that women with exstrophy feel we need to be doing better with? And I think this is the next frontier. It's not just surgical, but it is surgical, and it's looking at confidence. It's looking at perception of appearance. It's about self-esteem. It really gets back to supporting the parent and supporting the kid over time, and then supporting the kid who becomes the teen, who becomes the adult. And really, these feelings of shame and isolation need to be addressed, because everyone's perception of wetness is different. Someone can have a little leak on the liner and feel like that's the end of the world. Another kid's like soap pads and fine, wearing those special panties. So I think really individualizing that. Next slide. Pelvic floor issues, rates of infection, lack of knowledge by an adult urologist. I think that speaks to this concept of bringing in adult specialists and helping with that transition. More and more. I think this is a wonderful beginning, focusing on how bladder exstrophy does not limit, but where can we support and do better over time. And these are important areas that we have to listen to the women with exstrophy and the young men. We need to get them talking. That's a whole other topic. We gotta do the same thing in men, because I'm a urologist. I take care of boys and girls, and we gotta do better there too. So we know about the limitations, next slide, of these studies, but I think the future is bright, because I look at all of you in this room, and there's an incredible group of individuals that are here, and so it's to support you over your lifetime. Any questions? Please ask some hard ones, and then I will try to repeat that in the decision. Yes. Okay, so the question was, do we recommend pelvic floor physical therapy, and if so, what are the outcomes? The answer is yes, and the answer is it's very hard to access physical therapy experts, and so what we've done, and even for girls and boys who don't have exstrophy, right? A lot of kids take pelvic floor therapy, whether they have exstrophy or not. The outcomes, I think they are part of the solution, but we need to learn more about what type of physical therapy and how long lasting and when. So I think, but working with a physical therapist, I definitely think is part of the solution, and we'll see how far you get, right? And is that good enough? And then going from there. Other questions? Really? I covered it? Okay. Wow. All right. Well, I just want to say thank you to all of those of you who agreed to be on the panel later today. So the patient panel, and I look forward to hearing from all of you. Thank you.